Good morning, everyone. Good morning.
Good morning.
Thank you. I like a talk back, church. I am Councilwoman Felicia Porter, representing the 10th District and Chairperson for the Public Health and Environment Committee. Also joining us today are Councilman Mark Conway from the 4th District.
Thank you, Madam Chair.
We also have Councilwoman Odette Ramos from the 14th District. We also have Councilman Mark Parker from the 1st District.
Thank you, Madam Chair.
I don't see any other members. All right. We don't have any other members, and then we also have in attendance representatives from the City Council's office, and also, I believe, the Health Department and the Mayor's office as well. And the committee staff is Marguerite Kern. Today, we are continuing our discussion related to behavioral health in the city of Baltimore. And I want to highlight how important this work is. The Banner just shared the article earlier this week about additional PHA violations that were happening in the city of Baltimore related to sober house living. And while it is very, very detrimental of what's happening in the city of Baltimore, conversations like we're going to have today are so important about the healthcare quality of our recovery homes and residences, but also just healthcare quality in general as it relates to behavioral health and substance abuse. We cannot keep having these same conversations, the same playbook that is happening in Baltimore City without some intervention. And we've brought subject matter experts here today to talk through some of the state level regulations that we've been working on within this committee, but also in some of my personal work to make sure that we are not only connecting people, but we are protecting people in the city of Baltimore. And I'm super grateful to have one of the good ones here today to share some of the data repository work that she and her team have been leading the charge on. And so this, again, is a continuation of the conversation where we are with it as it relates to behavioral health. It's not going to be an easy fix. We have already said that before, but now it is time that we put some meat on our bones and really, really identify the root causes of these issues for a plan and an action forward. So I'll stop there and we'll go into public testimony. I see that we have one public testimony, and the reason for folks that are joining, the reason why we have public testimony first is because I want to prioritize the public. I believe that community should be guiding this conversation and guiding this plan of action. And so here in this committee, we start with public testimony first, and then we go forward with agency presentations and questions from the council members from there. So I'm going to start with Stacy Lovelace, one of my constituents from Pennington Avenue. And Stacy, if you could press the button, please. Yep. And also, just as a reminder, you have 2 minutes.
Okay. Good morning, and thank you for the opportunity to speak today. My name is Stacy Lovelace, and I stand before you as both a recovery professional and a woman in long-term recovery. This oversight is essential for reviewing Baltimore City's capacity to respond to the growing behavioral health challenges, including staffing, Baltimore City Health Department, data-driven evaluation, reporting alignment, city-funded, non-city entities, and the visibility of the pro-behavioral health efforts. But behind every policy and report, there is a person. They are not just a number. A woman fighting for her life, a mother trying to reunite with her children, a family hoping this time will be different. Strong relationships are at the heart of recovery. When individuals are known and supported consistently, they build stronger connections with themselves, with family, and their communities. Those relationships create longer, more sustainable recovery outcomes. To make this possible, we need additional grant funding peer recovery positions throughout the city, across the recovery systems, and including in recovery houses. Peers walk alongside those who are often lost in the numbers, offering guidance, hope, and accountability that no program alone can provide. Recovery does not happen on a fixed timeline. Programs may have 6 months or 1 year structures, but people should not be discharged simply because the time is up. Support must continue, with peers walking alongside individuals, not just through the programs, but through life, until they are truly stable, connected in their communities, and able to stand on their own. Multiple paths to recovery exist. I'm an example of one of them. It is our job to ensure the system provides structure, resources, and support that allow people to succeed on their own recovery journey. When we strengthen staffing, implement effective data-driven evaluation, align city-funded providers, increase visibility resources, and expand peer recovery support, including tracking and maintaining connection with individuals after they leave programs, we begin to measure what truly matters. Because right now, the system does not account for all the work that keeps people alive after relapses. The calls, the check-ins, the relationships that remind them they are still seen, still valued, still loved, and still worthy of recovery. That is where real impact changes. Recovery doesn't happen when time runs out. It only happens when support doesn't. Thank you.
Thank you so much, Stacy. And I just want to applaud you for coming from here today. I had an opportunity to visit Stacy's recovery home in Curtis Bay, and one, you heard firsthand from women that were in the program, but you also saw, just how one facility can change the direction of an entire block. And so thank you so much for coming here today.
Thank you.
I also want to underscore the work that's been happening with the overdose prevention strategy here in the city, that peer-to-peer recovery support that you're talking about, having those 24-hour mobile crisis teams. That's what the Restitution Advisory Board, that's all what we're talking about, and that's all what Sarah Whaley and her team are really pushing forward in this next iteration as well. So thank you.
Awesome, thank you.
All right. All right, before we go into presentations, are there any other public testimony? Any other public testimony for today? All right, hearing and seeing none, we are gonna go into our first presentation. Adrian, you wanna go forward first?
Happy to do so. Good morning. I'm Adrienne Bridenstine, the Vice President of Policy and Communications at Behavioral Health System Baltimore. I know I have a PowerPoint. I can also, there we go, thank you. So happy to be here back with the committee again to continue the conversation on behavioral health. I'm gonna focus today on mental health clinics, and then I have some updates on the state COMAR regulations, which I know have been a point of discussion with this committee, and how we address provider accountability. But as always, I like to start with who we are. Behavioral Health System Baltimore, we're the nonprofit and serve as the local behavioral health authority in Baltimore City. So in that role, we oversee the public behavioral health system, which means we work in partnership with the Maryland Department of Health to oversee nearly 300 programs across the city of Baltimore that provide mental health and substance use services to people that reside here. We also contract directly with providers that provide care. I'll keep going, maybe it'll catch up. So
Hold on
part
one
of
second,
our,
Adrian.
Sure. Part of our role is
Ooh.
that looked like the Star Wars screen there for a second. The force is strong with this one.
And so on.
Do you want me to keep going? There we go. Okay, so back to our core functions. So we are, system management is a big part of our role, overseeing and monitoring providers in partnership with the Department of Health. We do also manage public funds, so we get a significant amount of money from the state, feds, and locally, and we invest those funds in services that are not reimbursable through the public behavioral health system. So that means they're not a Medicaid fee-for-service funded service. Those types of services would include crisis services, peer recovery specialist, outpatient, or wellness and recovery centers, as just an example. We also do a lot of public education, most notably is around promoting 988 helpline as a major access point to care across the system. And then we have our local partnerships, a lot with, work very closely with city agencies like the police department, City Hall, the health department, to ensure that people have access to that system of care. So again, just continuing along with some state system context, the public behavioral health system in Baltimore City serves over 150,000 people annually. This is the most recent data that we have available from the public behavioral health system, broken out by the number of unique individuals served by the mental health system and substance use. Again, and so how that relates in spending, it's over $500 million that is invested in behavioral health services in this city. And you see it broken out, again, by Medicaid spending for mental health, substance use, and then the grants that I was mentioning earlier that BHSB invests for services that aren't reimbursable through Medicaid. So again, I'm going to focus on community mental health clinics. So to us, that means looking at the outpatient mental health clinics that we have in the city. What you see on the screen is just a map to show you the general distribution of where outpatient mental health clinics are, OMHCs, as we like to call them for short. And the bullets are the types of services that OMHCs provide. So and these services are not provided to everyone. So kind of want to describe it a little bit more. Everyone that comes into an OMHC will get their assessment and evaluation, but they get individualized treatment planning. So that could be that somebody does need group therapy or individual therapy. They may need case management, they may not. They may also need occupational therapy. Prescribing medication and medication monitoring is also a key service that's at OMHCs. A lot of times the people that receive services at OMHCs, in particular people with a severe mental illness, may need other types of community-based mental health services. That could be an ACT team that provides care. It could mean more intensive case management that that individual needs. And again, some of those services operate out of OMHCs, but not all of them. Again, just for some more context, this is the service utilization by adult and youth for the most recent year. We have data available, which is FY24. You will see a majority of people who are getting services, mental health services, are in the outpatient setting are adults. So one thing I wanted to highlight for this committee, because I know that we've had a lot of discussion on quality and types of quality clinics, is CCBHCs, or Certified Community Behavioral Health Clinics. This is a federally defined model that we do have in the state of Maryland, and we have 3 operating in Baltimore City. It's a federally defined model for behavioral health care, and it's an integrated care model. CCBHCs are required to provide comprehensive mental health and substance use services, so that helps to get to that integrated piece. But they also provide a lot of somatic care to help improve the overall health outcomes of the people that they're serving. The reason we really like this model and think that it's a higher level of quality for a behavioral health clinic is there are clear expectations and outcomes, again, that are outlined by the federal government that clinics must perform on. One of the things that make CCBHCs higher performing and a higher quality type of clinic is that they are required to offer care coordination. So that means that they bring all of the providers that are working together on a particular, to serve a particular patient or all the patients, and they're closely coordinating their care both within that clinic, but also services they're getting outside of their clinic. It seems like common sense, but it is not something that happens widely across the system, mostly because it's not paid for in Maryland's fee-for-service system. CCBHCs are also have pretty extensive data reporting and accountability that they're expected to report to the state and the feds. But one of the things that's unique about this also is the payment model. The payment model is aligned with outcomes. So the way it kind of works is the prospective payment model. CCBHCs are given an amount to serve that patient that they're serving, and they are expected to achieve certain outcomes. So it's a different way of paying for things versus how we pay for things now, mostly in the public behavioral health system, which is fee-for-service, means we're paying for volume. So I wanted to highlight this because I know in this committee we've had lots of discussions around what is a high-quality clinic. We view CCBHCs as an example, one example of a high-quality clinic. We have 3 of them that serve Baltimore City, Shepherd, Pratt, Gaudenzia, and Volunteers of America. They are serving Baltimore City now. Oops, let me go back. We would like to see this continue. There are only 5 across the state, so I think we're fortunate to have some in our area. We would love to see this expand. We've done significant work this Maryland General Assembly legislative session to support the state to expand CCBHCs. In fact, today, the state MDH is submitting their application to the feds to continue the planning for CCBHCs statewide. We hope their application is a successful one, because that will help continue to bring these types of higher quality clinics, keep the ones that we have, but also continue to kind of expand this model across the state. And then finally, just for this piece, I wanted to highlight Access for Care. You've all heard us talk about 988, the 988 helpline. It operates 24/7. It's free and confidential. One thing that I don't know how widely known it is that you can call 988 to get access to clinics, and you can also call it to get same-day appointments to outpatient clinics across the system. So it is the major access point to the broader system of care. It is a tool that people can use if they are in emotional distress, but it's also the number people can call to get information about mental health and substance use services across Baltimore City, and they can get directly connected to an outpatient clinic for an appointment the same day or possibly even the next day. How we look at outcomes for the 988 helpline is if we are able to resolve things without needing a higher level of care. And you see that on the screen. A majority of the calls that come to 988 are resolved over the phone. That's what we want to see. That means we are not sending people to the emergency room. That means we are not involving fire or police in helping to address their issue. So that is how we're that's what we look at in terms of outcomes for the 988 helpline. So I'm going to shift to provider accountability. And again, this may look familiar to you as well. One of the pieces, or one of the things that we do as the local behavioral health authority is, in partnership with the state, is provider accountability. So monitoring the quality of providers and their outcomes. As I mentioned earlier, BHSB invests around $64 million in services that aren't reimbursable for Medicaid. So that means we contract with a range of providers in the city. We audit every contract, every program that we fund on an annual basis to ensure that they are achieving the deliverables that are outlined in their contract, and that they're achieving the quality that we expect of them. If they are not, we will work with that provider on putting them on either a corrective action plan or a performance improvement plan if that's necessary. But we're always looking to make sure that the programs that we directly fund, where we have direct authority and influence over, that they are performing at a high level of quality. We also investigate complaints for any type of behavioral health program in the city. So that can be ones that we fund directly, but also ones that are licensed through Medicaid and bill Medicaid for services. We do that in partnership with the Behavioral Health Administration. In addition, in partnership with the Behavioral Health Administration, we will also investigate and track critical incidents. So those, that's what you see on the screen. A critical incident is a bit different than it's a complaint. It's a more serious incident that might happen at a provider, and it's such as a death, an overdose death, or staff misconduct. So the way we have complaints, we take them verbally or written. I've received them from a number of you. Thank you. You can always reach out to me as council members or put your constituents in touch with me, and we will take their information and issue a complaint. But our role as assistant managers, we're responsible to investigate any of the complaints that come in. There are situations where we cannot investigate because we may or may not have the authority. So Medicaid fraud, for example, that's something that needs to go to the state and that they would be investigating. When services have been not denied by Medicaid. So anything like that, that's something where BHSB does not have any authority. The tools that we use when we investigate are what you see on the screen there. So when we do have a complaint that comes in, we always encourage people to give us their contact information, because our investigations team will follow up directly with whoever made the complaint to gather more information. We will then take that information and, based on what the complaint is, do some kind of record review, do a site inspection, either announced or unannounced, depending again on what the complaint is. We will interview staff or participants at a particular program. We'll look at policy and documentation. So there's a variety of tools that we will use to investigate complaints, again, depending on the type of complaint that comes into us. When we do get a complaint, I just kind of went into this, we will contact the person, we'll do the investigation, we'll try to verify the information. The next step that we do is we make our recommendations. If we are able to verify that there is an issue there based on the complaint, is we will make recommendations to the Behavioral Health Administration on what we believe the corrective actions should be. And then we wait to hear back from them on if they approve for us to move forward with what we propose. Oftentimes that involves either putting the provider or program on some kind of specific corrective action plan or performance improvement plan. In addition to that, we offer guidance and education. It does not often lead to a program being closed automatically. If it's something pretty egregious that it would need for a program to be closed automatically, that's usually a higher, more serious type of complaint or incident that BHSB doesn't have the authority or decision-making power to do. So here's what you see on the screen. Last year we had 86 complaints, and here are the sources from the complaints. Majority are coming from Medicaid. You can always make complaints to us. This is how you do it. We've got an online form. It's pretty easy to follow, but as always, you know how to get in touch with me, and I can be helpful if I can be helpful with that. So the last piece I just wanted to cover today is, again, continuing updating this committee on where the state is with COMAR 1063 revisions. So this has been an ongoing process, but for some quick context, the COMAR 1063 are the state-level regulations that govern community-based behavioral health programs. So that's both the mental health and substance use, anything that's licensed or certified through the state. So these regulations historically have included definitions for program types and provider types, rules for licensing, and general accountability and compliance expectations. They've gone through a significant rewrite. So just as an example, the process that the state's been going through is, again, the significant rewrite. There were 9 chapters. They're now moving to having 39 chapters, just to give you kind of a sense of how extensive the rewrite of this has been. They're intended to help improve and address provider accountability and quality, which has been an ongoing issue, I know, in Baltimore City, and something this committee's been focused on, but also across the state. It establishes new expectations for provider types, and I will say, I think Kim, you'll agree with me on this. I think they're easier to follow, too, moving to 39 chapters. Each service type has its own chapter, so if you want to look and see what the regulations are generally for providers, it's got a couple chapters in the beginning, but then you could go look up what it is for recovery residents. You could go look up what it is for IOPs or outpatient programs. So I do think it's organized in a very good way. And we can get into that detail if you have specific questions. But it is broken out. It has specific expectations for different provider types that, again, are licensed through the public behavioral health system. So this is the timeline. As you can see, this process of rewriting them started nearly 2 years ago in the summer of 2024. So, they've been rewriting them. I'll just kind of jump ahead to where we are now. The department has made significant progress since the beginning of the year to really wrap these up and finalize getting the stakeholder input needed to get them to a near final state. They convened the stakeholders actually last week, where we honestly expected to have a 2-hour meeting, and it ended up being much shorter because they did a lot of work between beginning of January this year and March to work with stakeholders to come to compromises and address the concerns. So where we are in terms of timeline is I do think that the regulations will be in effect before the end of the year. The department the regulations are now moving out of BHA and going to BHA's regulatory office for review, where they will then go to the secretary for her approval. But they are also going to the governor, which is a unique step. And that is just because it is such a significant rewrite. Again, going from 9 chapters to 39. I want to make sure the governor is informed on what this means for the system of care. After they go for his approval, they will go out for public comment, which is then open for 30 days. I hope and knock on wood expect that they will get a lot of support this time around, and that will not mean that the department will need to do any kind of further edits after that, which means then they'll go into effect sometime later this year. So I'm hoping fall or the end of the year. I don't know. What do you think, Kim? Should we? We're knocking on wood. But when they go into effect, we think this is important. COMAR is one tool, as we've talked about with this committee in the past, one tool that can help to address improving a provider accountability. There are new expectations in COMAR this time around, and there are also new expectations around compliance for what's expected for all program types. So we're excited to see that these go into effect. We want to see, one, if it'll help over time. Again, right, it's going to take time to improve quality, but it will also, I know one of the things this committee's been concerned about is they've talked about having too many types of providers in certain areas of the city and too many new providers opening. Given the new expectations there are around initial licensing, this could slow that as well, which I know is something that this committee has been focused on. So we're excited to see these go into effect to see if they can have their intended effect. So I think that's all I've got for today. Thank you for the opportunity just to give you this update and talk to you more about the system of care, and I'm happy to take any questions.
Thank you, Adrian. And committee members, I want you all to feel proud, because remember that committee with Deputy Secretary Alyssa Lord, and the feedback, we had a follow-up after that meeting. The feedback from this committee really helped to distinguish and place the Baltimore City stamp on a lot of those COMAR regulations. So a lot of the inconsistencies that we're seeing in community related to quality, what we're seeing related to provider accountability, what we're seeing to data repository and triaging, that you'll see as those regs come out, you'll see it represented in those regs. And you all should really feel proud that you all had a play within this committee at the state level and making sure that your constituents were being heard at that level as well. So thank you again. Colleagues, I'm going to go to Kim real quick, and then we're going to go into a round of questions. All right, Kim?
And I will just add to COMAR that, turn that on. Is that on? I will just add, can you hear me? Oh, okay. I will just add that provider organizations, Maryland Addictions Directors Council and Community Behavioral Health were very strong advocates for changing COMAR, very strong advocates. And I also want to say that BHA was so collaborative in working with providers who wanted additional COMAR, who advocated for toxicology to be included in the first time in COMAR, toxicology standards for different levels of care, supervision ratios, so that you can't have one supervisor for 300 clinicians. It's now 1 to 15. We advocated for that, and BHA responded. Caseload ratios. A lot of this was stripped out in 2018 with the best of intentions when we moved to accreditation. And unfortunately, again, with the best of intentions, the system conflated quality assurance for effective regulation. We're now, many years later, knowing that that probably wasn't the best assumption. So these new COMAR regs have widespread support by providers. We are very grateful to BHA and very anxious to see them implemented, and to BHSB for their advocacy and support. So I just wanted to add that and tell you a couple of the ones that we're most supportive of. Well, now that I've already started, thank you very much for the opportunity to present to you today. I'm Kim Wireman, president of Powell Recovery Center, and I'm here to talk just a very little bit about background on Powell. to touch on our quality assurance system, and then to present an integrated data warehouse that we've been working on in response to what we see to be some of the largest holes and blind spots in behavioral health treatment, specifically SUD treatment. Our goals in all of this are to shape better treatment, intervene more effectively, and save lives. So let's see if this works. Great. First, I'm just going to give a very brief overview about PAL for those of you who may not be familiar. PAL Recovery Center has been located in the same place in East Baltimore on Broadway for more than 30 years. We have a full continuum of care that includes 275 licensed residential beds for our clients, as well as a full continuum of outpatient care. We also have an outpatient mental health clinic license that Adrienne was speaking of, where we have a psychiatrist and licensed clinicians who provide seamless dual recovery service for our residential clients. As you can see from the demographics, most of our clients present with absolutely no psychosocial resources and homeless or in very tenuous dependent living circumstances, so most of our clients are presenting for residential treatment. You can see from our demographics, we reflect the city that we serve. PAL has been developing what we call, and what we haven't coined, it's a phrase, practice-based evidence. We're seeking that, and you can really substitute practice-based evidence for what's working now. We've been developing practice-based evidence so that we can strengthen treatment quality and we can report meaningfully on outcomes. I think everyone knows there's a large gap now in reporting on outcomes after treatment. We've built a robust quality assurance program. I was here in July presenting on that, and I had umpty-ump slides about our quality assurance program. Happy to repeat them in future if anyone would like a repeat, but today we asked ourselves, after that, we continue to ask ourselves what more we can do. And when we saw that an integrated source of a client's whole journey, what we call an integrated data warehouse, for what's working, measuring what's working now, and what we can do to adjust in as close to real time as we can to meet that need, not only system-wide, but for the individual. I so endorse what our public testimony had to say today. She beautifully summed up the whole reason for why we're developing this data warehouse. Every individual is important. As background to our quality assurance, very briefly, in early 2024, we knew that we were missing a piece, and that was our clients' experience. Our clients have expertise on their own treatment experience, and we wanted to capture that in order to save lives. We also knew from our own data that if we can get a client to stay for 30 days in treatment, that client has a 70% chance of completing a 90-day treatment episode. And there is no one who completes a 90-day treatment episode who does not benefit from that treatment episode. So our first goal was to look at the front door, because if you can't stay 5 days, you can't stay 30 days. We looked at 3, 5, and 7-day retention as part of our overall goal to increase 30 and 90-day retention. When we looked at what we had, we thought we were pretty snazzy. We had walk-in treatment, immediate access to BUP, immediate mental health triage for those who needed it most, immediate access to food, clothing, and personals, and we measured 30 and 90-day retention annually. Well, when we took another look, we saw how much more we could add. We had client choice we added client choice for immediate access to BUP or methadone at admission. We increased client choice with regard to BUP dosing in that first day or two, where the client's experience really informs the right next move. We had client surveys on extinguishing withdrawal symptoms in the first 3 days, not from the clinician's point of view, but from the client's point of view. We put over-the-counter comfort meds in our residential units so our clients had access to them any time of the night or day that they needed them. And then we asked our clients, how helpful are those comfort meds, to get their view. We introduced CBD. The CBD does not have THC in it. We introduced CBD as an additional over-the-counter comfort med for our clients on a 21-day protocol. We put intensive case management right at admission. We have a Topamax protocol for cocaine dependence and a BuSpar protocol for clinical anxiety that we test at admission. And then we measure 3, 5, 7, 14, 21, 30, and 90-day retention every month. So we have a dashboard to see how we're doing. Just as an example, I only have 2 slides of the quality assurance, but just as an example for those who maybe didn't see my presentation in July, here we have client response indicating their drug of choice, their primary drug of choice. And then this is the overall client's view of how their withdrawal symptoms are being extinguished during the first 3 days of treatment. And you see for opiates, cocaine, and alcohol. The good news is we're seeing a definitive drop, but of course there is always room for improvement. And this continuing survey gives us the ability to immediately see how we're doing extinguishing symptoms as we see additional elements mixed in the fentanyl supply in the city. Next, we have the client view of how helpful the comfort meds are. We looked at comfort meds most used, and then we looked at the client's rating for helpfulness of the comfort meds by their primary drug of choice. And again, we don't expect the comfort meds to be in and of themselves, significant, but in combination with other treatments, especially bupromethadone. Below, we have the client's view of our CBD, which had overwhelmingly positive data for anxiety, stress, focus, help with sleep. It's remained amazingly positive. Those 2 examples, as well as a plethora of other things that we are measuring, resulted at the end of our fiscal year 25 with some results that even astounded us. We increased 3, 5, and 7-day retention by 9% each. We increased 30-day retention by 7%, and we increased 90-day retention by 8%. We were immensely pleased with those results and continue to ask, what more can we do? Here's just a little chart to show you the many other things that we measure. As I said, happy to review that with anyone who wants to see 52 slides on data. But we're measuring a great deal so that we can really ascertain the client's view of treatment, what's working. We survey our employees so that we can see how they're doing, and a number of other things to measure our treatment. In asking what more we can do, we know that behavioral health care treatment and SUD treatment in particular has a number of blind spots. The provider can't see what's happening with their client when they're not actively engaged in treatment. But we know that we work in an industry where for the past 70 years, the statistics have clearly indicated that 40% of the clients leave treatment in the first 30 days. It doesn't mean they don't return to treatment. It means that there's a continual churn in SUD treatment that's very typical. So we have this huge blind spot where we're seeing fragments of the client experience when that client's in treatment, but we're not seeing the whole client journey that actually Ms. Lovelace spoke about so effectively in our public testimony today. We also know that the system has an urgency of now in treatment, which is not a bad thing in a fentanyl epidemic where people's lives literally are at risk, but nonetheless, it puts the focus on what's happening immediately now. We know that our reimbursement system reinforces that focus on what's happening now in the treatment system. Value-based reimbursement systems may change that a bit. They've been talked about for a long time. That may be something in our future. We know that scholarly research uses a scientific method to evaluate outcomes in treatment, and that typically that takes a great deal of time in the rigorous scientific method, so that when we're reading about articles that have important information, typically that data is 2 to 3 years old. And we looked around to see if there was a source, what we call a data warehouse, a source of data that attempted to give the long-term view of the client's experience, and we couldn't find one. So we built one. Here's a representation of our data warehouse. You can see we've taken our electronic health record, NetSmart. We regularly drop it to an agnostic platform. That's a fancy word for no fancy software is needed to access the data. And then we've connected, we have our own lab, but we have an open system for additional labs and what they call an HL7 connection. Lab and toxicology, we've connected our client surveys, so they're included in the data warehouse. Pharmacy records, the health exchange. We just completed automating the case search for Maryland Judiciary Case Search so that we have our clients' interactions with the criminal justice system included in the data warehouse for evaluation. We have a connection with Vital Records. Homeless services in Baltimore City is purple because we still don't have that connection yet, but we're very dedicated and anxious to working with Baltimore City so that if our clients, our active clients, are in homeless shelters, we can approach them to see what additional support they may need. When we look at this data and we look at practice-based evidence, what's so important to us is that we look at the individual and how this information impacts the individual as well as the system, in addition to being able to report outcomes. So we're not just compiling information to report outcomes, we're compiling information in real time to affect the individual client in real time, as well as see what's happening in the system in real time for adjustments. We have 3 journeys that we've looked at. These are retrospective, please know they're not current. We have 3 journeys that illustrate how this system can be effective for the individual, and we're only using one piece of the data from the data warehouse. That's the health exchange information, emergency room visits and EMS visits. So we have 3 people, Alan, Brad, and Charlie. The names have obviously been changed. All fentanyl dependent, all 40 to 45-year-old African-American men, all without stable housing at intake, and all having had significant ED visits in the 30 days prior to intake at PAL. We have Alan, the survivor. Alan had 3, as you can see on the blue dots, Alan had 3 admissions prior to his relatively short first treatment experience of 28 days. He left treatment. 13 days later, he was in the ED. He received a warm handoff back to PAL and had, at the time the slide was made, a 91-day treatment experience that was very positive, and was alive with 740 plus days counting, hopefully living a fruitful life. We have Brad, who was the unfortunate loss. He had 5 ED visits, as you can see, prior to his short stay at PAL for 13 days, and then he had 12 ED visits in 2 months. Brad, unfortunately and tragically, died of an overdose 74 days after discharge. We offer this slide, and again, this is a retrospective view. When we developed the system, we looked retrospectively. We had 12 opportunities. What this slide indicates is with this information, we had 12 opportunities to reach Brad, to see what support he needed. And I'll emphasize, this doesn't always mean a return to residential treatment. It may mean Brad needs additional support for his diabetes. It may mean that he needs connection to harm reduction. It may mean a variety of things based on the client's choice. But what we want to be able to do is intervene in these instances. And then last we have Charlie, who we call the opportunity. He had 7 ED visits 30 days before entering a short stay at PAL, 21 days. Afterward, he had 15 ED visits. He is, to the best of our knowledge at the time the slide was made, alive, but at risk. And again, 15 opportunities when he was in the ED to approach him, to support him. And I certainly am not saying that no one in the ED did this as well. But when the system is working together, this is the kind of information that we can provide to impact individuals immediately. If we knew that he was in that first emergency room visit after his 21-day stay, we would have sent our community outreach to that ED, to that hospital to see if he wanted to see us and attempt to re-engage him. We looked at best practice for reducing ED use, and the research all says the same thing. There's very little best practice other than relationship. So that's why we want to leverage our relationship with these clients to intervene in the most urgent possible way. Well, it's clear individually that we can make a difference with this information with just one aspect of the data warehouse. But we also want to bring those stories to scale and understand what's happening in the system. We want to be able to look at patterns of survival. We want to identify patterns of loss and work against them, and we want to create pathways to opportunity. So we offer this as an example. We took a 365-day period during which we had 815 clients in residential treatment. Now, this 365-day period, some of them were in treatment, some of them were out treatment. It's a very dynamic period. There were roughly 1,300 emergency room visits from our clients during that 365-day period. Again, some of them were in treatment, some of them were out of treatment. What we found is that those 1,300 visits were by 165 PAL clients. We have no way of knowing this unless we have this kind of information. We don't know it anecdotally with clients presenting. So what we saw immediately was 20% of our clients are providing 100% of the emergency room visits in that 365-day period. What we also found is that treatment bends the curve. We saw a 52% reduction in ED visits during that 365-day period after clients entered treatment. We also saw that 44% of PAL clients with an ED visit before admission had no ED visit after admission to PAL, again, for that 365-day period. So we see that treatment bends the curve. Why? Because we're connecting our clients with primary care, we're educating our clients, we're providing transport, we're talking about nursing lines, telehealth, and all of the flexibilities that make that primary care more accessible. I also would say that a number of the primary care providers that we use also have transportation for clients. So we saw how treatment bends the curve. But then we divided the client, per client ED visits, and we were really shocked at what we saw. Again, no treatment provider understands this anecdotally from clients presenting one-to-one, one-on-one. You have to have this information in some kind of ability to report back. What we saw when we broke down ED visits per client into quartiles, like they do in research, we saw that 30 clients have gone, in that 365-day period, 30 clients went to the emergency room 829 times. So 30 clients are responsible for 66% of the ED visits in that 365 days. Really shocking. But what we also learned when we were presenting this data to a researcher who had done some work in this area, she identified that this pattern is typical. So we don't, hypothetically, we don't believe that this is indicative, this very concentrated ED use is indicative of SUD clients in general or PAL clients in specific. It's a phenomenon. You have a small number of clients who use a great number of visits. But here's the deal. We know who these 30 clients are. Some of them might be in treatment with us. We can interact with them to find out what's going on and change this trajectory by education, by connecting with primary care, by a host of supports. What we find in so doing is that our clients are so open to education about how to get a primary care doctor, how to ask for a prescription refill. I'm talking about real life interactions with clients. It's not some hypothetical nuclear science. It's talking to people about how they interact, how they call, what services are available. And so we never knew. We never knew that we had 28 clients who were going to the ED 163 times. So this is systems data that can really change trajectories for the whole system as well as for the individual. We not only know who those 30 clients are, with our data warehouse, we know where they're going to the hospital, where they present. We know the day and the time they're arriving. We know why they're coming to the ED. With all of this information, we can not only report on outcomes, not only give really incisive information about what's happening now, today, this week, but we can drill it right down to the individual clients and attempt to intervene with those clients. We have one example to show you, Xavier, a survivor. He had 10 ED visits in that 365-day period, 2 admissions to PAL, the first one very successful for 185 days. He had 3 ED visits during his treatment with PAL. All of them were for somatic care for his hypoglycemia. He had a very successful discharge from PAL, And then, unfortunately, immediately, and again, we're looking at this retrospectively. We weren't looking at this in real time because we didn't have the data warehouse developed. But, and then we see the pattern return. Xavier, as soon as he's leaving treatment, he has 7 EMSs, 6 ED visits, including 3 psychiatric episodes. No psychiatric episode is unnecessary. We're glad that there's a resource for folks who need immediate psychiatric care. And then he was back at Powell. He did have 1 ED visit at the time the slide was created for his hypoglycemia, which clearly needs additional care. If we had known that Xavier was restarting his pattern, if we had known the first time he went to the ED, we could have intervened and possibly changed this trajectory. I hope you see that the value of practice-based evidence and using even one slice of information from this data warehouse has a tremendous ability to not only create tremendous benefit for individuals, but to influence the system overall positively and to be a tremendous source of the outcome data that we're now missing. We believe that this is essential to shaping better treatment, intervening more effectively, and saving lives. I'll leave you with a final vignette, and that is, if I can get through it. We had a young man, young to me, in his early 30s, present for treatment about 3 months ago. That young man, when he presented to treatment, was legally blind. We immediately connected him with intensive case management because clearly he needed additional support, but he was entered residential treatment. Case management, intensive case management, working with him, discovered through their interviews he was diabetic. He had absolutely no idea how to care for himself. He repeatedly went to the ED in crisis for his diabetes. And we, when connecting him with medical care, found that his blindness was caused by his inability to take care of his diabetes. It's 2026, and we have a young man in his early 30s walking around legally blind because he doesn't have adequate care connection for his diabetes. Through his successful stay in residential treatment, working with case management, talking to him about intervening with medical care, transporting him to appointments and encouraging him and educating him. Not only the primary care educating him, but Powell's intensive case management educating him. He has successfully completed operations for both eyes to restore his sight. And we can't say that without immense gratitude, not only for the work we're doing, but knowing that that young man has much to see in what we hope is a long and fruitful life ahead.
Thank you so much, Kim. And I just want to thank you for showing up today. Colleagues, I had the opportunity of viewing this presentation over the summertime, and the reason why I brought Kim here today is because we have something that's actually working in community. We have a template that we can begin to rally around from a data interoperability perspective, but also from a clinical community-based intervention perspective. And the healthcare quality measures that I talked about developing in this committee in collaboration with BHSB is going to fuse these two interventions, one from a policy route, but one, Kim, I'm gonna share your term, practice-based evidence, from that perspective, so that we are combining data, precision medicine, but also we're looking at where folks can be now and in the future as it relates to any type of intervention, whether it be from providers, whether it be from city, whether it be from the fire department. We are able to see that in at least to some sort of level of strong detail. We are able to pinpoint where we are putting our care coordination, but also where we are putting our dollars for city budgets as well. And so this is an opportunity for us to merge and marry these two so that we at least have some sort of way in the behavioral health sphere that we can begin to directly coordinate with agencies, with community-based organizations, with hospitals, and also the person as well, so that they can truly, truly, truly live a higher quality of life. So I thank you both for coming today. Colleagues, we're now going to go into a round of questions from community members. I will save my questions because I talk to these ladies pretty regularly, but I did want to make two formal committee requests, two to Adrian. You talked about the audits reports that you all provide. I'm wondering if some sort of aggregate level data can be provided to the community. I mean, not community, heavens. Can be provided to the committee. And the reason why I ask that, colleagues, we're often kind of fighting in the dark about what some of these issues are related to what's actually happening in community. And the reason why I'm asking for these audit level reports to the committee is, one, we are able to generate new ideas within, whether it be a committee, whether it be a special topic that you are focused on, like housing, like public safety and government operations, land use and transportation, the immigrant community. We are able to we're able to have a more concerted discussion with some policy ideas that we can put forward. So are we able to share that aggregate level audit data with the committee?
I know we do have aggregate data on like the volume numbers that we've done.
And I'm specifically looking for the types of complaints. So like,
so complaints or audits, those are different.
So like the audits that you were talking about were for the providers, and you talked about, and yes, talk to me about the audits real quick.
So we audit every contract that we have with the program.
Oh, yes, I remember my question now. Yes, it is the audit level data to see whether they're effective or not. And so the funding that, and correct me if I'm wrong, the funding that those organizations get, the city council has ties to them. And so this is just showing their effectiveness. So whether they're effective or not, that was my question for that one.
So we look at audits. So audits are, an after the fact look, right? Did the program achieve its deliverables? One of the other things we do while a program or in the middle of a contract is we monitor a program throughout the year to make sure that they are on track to achieve their deliverables. So I didn't talk about that in my presentation, but those are two things that we do to work with, again, the programs that we contract directly with to make sure that they're achieving their intended outcomes.
Okay.
I can look at what aggregate data we have on audits.
Yeah.
But if you are interested in a specific type of program and its outcomes and whether we're, getting what we're paying for, that's very individualized, but I can also look at that too if you have something specific.
Yeah. How many organizations do you all work with? So the ones that are connected to the city.
300.
No, so I'm thinking of ones that are specific, like service providers. I believe there are like 12 or 20 service providers that are connected to BHSB and also within like substance abuse, mental health, crisis management space.
Okay.
And the reason why I'm asking for that aggregate level data is because we are now coming up for budget season, and it'll provide the committee members with an opportunity to see what, the best use of our dollar, if there's any increase that's needed, how we can advocate for that.
Yeah. So the behavioral health crisis. Yeah. Okay. So we we do have a lot of data on that. A lot of it's actually publicly available on our website, so I can send that to the committee for follow-up. We publicly report our outcomes for the 988 helpline and then for mobile crisis services.
Okay, that'll work. If you can send that link out, that would be great. And then the second one is, again, the data regarding complaints, what types of complaints we are getting.
Okay. Yep.
And then also I would love to see it at the district level, where they're coming from.
Okay, let's see what I can do.
All right, colleagues, you have any questions? Conway?
Thank you, Madam Chair, and appreciate you pulling this together again. Kim, great seeing you. Adrian, always a pleasure. I appreciate you guys. I had an opportunity to come see your work, I believe it was last summer, and you weren't there, but your staff was amazing. As a data guy, I really, really appreciate the detail that you guys put into tracking folks and seeing outcomes. I think it's something that we should have really everybody doing so that we can assess what is and is not working. This is a very simple question, and I'm not sure if you have it on the tip of your fingers, but what does it cost to operate your database? I don't have it on your microphone.
I don't have it on the tip of my fingers, but I can tell you we've developed this on our own because we have very dedicated people, because we see the intense need for it, because we wanted it, in frustration at the fact that we can't get reports and the system doesn't have long-term outcomes. So we've developed it with no additional funding because we have highly talented, very dedicated people who wanted to develop something like this. I can get you costs. So what it's cost us isn't reflective necessarily because people have worked at a deficit so that we could afford it. But it's been designed to be very open, and we're not, let me be very clear, we're not developing a commercial product. We're developing a tool. We're a 501c3. PAL's a 501c3 dedicated to giving back to the community. And so we're developing a tool for ourselves, but also for public health. So our whole intention in designing this is to make it accessible to a system. And I think that answers your question. It's not, we're not, I can get you dollars, but it's intended to be accessible to the public health system as a tool for public health.
And as a sort of party to that question, how time intensive is it to collect data, pull reports, and otherwise? Does it take?
Well, it's all automated through that connection. So it's an automated drop down, and so that's happening every day or every week, depending on what the interface is. So the system runs itself. Now, you do need technical people, and if the system were to expand, you'd need more technical people.
Sure.
And I'm sure everybody knows they don't come cheap. Yeah, they're expensive. But the system is absolutely designed to be as low tech as possible because we intend it, if we get the opportunity, to be able to expand it to public health. We see the benefit for PAL, but we also see the benefit for a system in being able to use a data warehouse like this. And we don't think there's any other one being developed. I mean, I don't want to pat myself on the back too much, but we really do think that we're at the beginning of something very, very meaningful in terms of looking at individual system practice-based evidence now, and also expanding the ability to report on outcomes, absolutely, which is what isn't present now. So I can't answer the money question. I mean, I could tell you what it cost us, but that wouldn't be what would be reflective of what it would cost to leverage it to the public health system. But none of this is, I hesitate to say, none of this is expensive. None of it is expensive.
It's good to hear.
Yeah.
I would imagine.
No, this is not, yeah, we're not developing a commercial product. We're developing a tool for public health because we want to use it and because we want to make it accessible to a system in order to advance treatment and save lives.
That's good to hear. To that effect, Adrian, you talked a little bit about COMAR 1063 and the updates that were being made to date. Is that a bill, or is that just... How are those updates being made? Is there a bill that's going through MGA, or?
It's at the regulatory level. So
Okay.
at the department they've been going through this process of updating COMARs for almost 2 years now.
Good.
There has not been a bill requiring them to do it.
To the data question, my thought is, and I'll walk you through my logic here, our best opportunity to improve quality is before you open up an operation. It's making sure that they have the good people, good processes, good accountability, and then you have to do spot checks down the line. I would imagine with some sort of data required as part of that operation, you could do a much better job of seeing, sorting out the good from the bad, and where things are or are not working. And so to that question, for the regulations that they're updating, is there any data component that they're considering requiring as part of the licensing? And if they are, is that something that they might make public? Because I think there's a component of, there's not much information out there available to patients that are looking for quality care to determine the good from the bad. And so they go to the closest one to them and don't necessarily always get the best service. So if you can answer that question, it'd be helpful.
No, I really appreciate that question, and that is something that we've been thinking about at BHSB, especially now, now that COMAR is in a near final stage. So let me take a step back. There are new expectations in COMAR that I think could point to improved quality. Kim talked about some of them. The patient to service provider ratio is one. There are licensing expectations for the type of staff that you need to have hired to provide care at these different programs. There's also a whole subchapter on how a program is expected to do compliance or ensure that they stay in compliance, including having dedicated staff at your program for compliance oversight. So that's new. So again, I think those are some pieces of, just example of pieces in COMAR that can help to address quality. But how can we, the other thing I think we need to look at is how can we be using COMAR to push quality? And how can we go above what's in COMAR? COMAR is the floor, in my opinion. That's
Right.
the expectation of every program operating in the public behavioral health system. What else do we want to expect to that provider to improve quality? You know, should they be doing case management? I think they should be offering case management. We don't pay for it, right, in the public behavioral health system, but it's a really important piece of ensuring that there's a good quality program and that helps you achieve outcomes. So one of the things that we've been trying to think about at BHSB are what's some tools that we could create that could help the public understand, like, here's a quality provider. They're doing this, this, and this, and that's what we believe is a quality provider. I don't have anything specific, but I do think now that we know what the new floor is going to be, that we, with COMAR going into effect, that we can move forward in taking those next steps.
If I can make this a follow-up request for the committee, and Adrian, you and I talked about this idea before, but I sort of look at the licensing process as an opportunity to highlight those that are going above and beyond. Certainly there's the standard just to get a basic license, but maybe that standard is too low, which is why we're updating COMAR. But I think there's also an opportunity to highlight those that are going above and beyond and offering the highest quality of care that we understand to be available today, whether it's, medicated assisted treatment or therapy or having a licensed physician on site or anything like that, or having smaller numbers, so on and so forth. I think those things can be indicative of a higher quality opportunity. And now we'd have to check the data in order to make sure that that is actually the case. And then I think also what I'm asking here is there a requirement in the licensing process for data to be reported to the state so that we can have a regular update on outcomes, on output from various providers?
There's requirement in the licensing process for programs to report to the state if they had any is the findings the right term, Kim, with their accreditation? Like they have to.
Yeah, I can fill in
Please.
a little
If you-
bit.
yeah.
Right? Since I'm in the salt mine,
Okay.
let me just, an accrediting company, in 2018, we required
Joint
providers
commission
to
or-
be accredited.
Yeah.
Now, I think if I say this softly, that accrediting standards are implemented differently by each of the different companies. And I think BHA will tell you that they see one accrediting provider with maybe different standards, maybe easier standards, I don't know, than others. That would be something for BHA to comment on. Most accrediting agencies have about 2,400 standards that you have to meet, and they come in every 3 years with your license renewal, and it's time now with your license renewal. For PAL, they have 3 to 4 representatives on site for 4 days. That's a really thorough audit. All right, that's ACHC. That is an intensely thorough audit of those standards. And then they write up a report and they write up a plan of correction, if there is a plan of correction. Typically, we have a very, very minor plan of correction, knock on wood, now that I've said that, but they have a plan of correction. That plan of correction is submitted with your license renewal or with your initial licensure. And it details what standards you may need to improve on. Now, sometimes, I'm sure those are 50 pages long. Sometimes they're a couple of pages long. And looking at each one of the items is important because they could be something very small, but it didn't come up to the standard. Typically, accrediting agencies are not anxious to ding you for something small. The plan of correction is an excellent way to see what the bandwidth for quality is. It's one indication, it's not the total picture. That's one indication that's from an outside agency that can be reviewed systematically. I think you can even put them into AI, you can put them into ChatGPT. You don't need a staff of 85 people to read them in order to score them and be an indication. The other thing I would say, Councilman, is I think you're right that licensing is a critical point in the system, but I think the issue that we're facing now in Baltimore City that I know I'm preaching to the choir that so many people see is that since 2018, those licensing standards haven't been what we all might have hoped they would be because of that conflation of quality assurance with effective regulation. So we now have a market that's dysfunctional, right? We all agree that there is some element of significant dysfunction in the market, and that also needs to be addressed through data. But there is, I don't work at the systems level, so I don't see all of the systems level issues. I'll say that. So take what I say with a grain of salt, but Maryland Addictions Directors Council and NCADD worked together on this issue with recovery residences. And we put together a list, we got a list of all the licensed PHP, IOP programs. You could include PRP if you wished. In 2 counties that we're working with. We weren't working with Baltimore City. And then we got a list of all the MDRN funded programs. That's the block grant housing, which is supposed to be providing independent housing, but is really in practice linked to the provider system. But we could see who was delivering PHP and also had MDRN funding, right? Because typically those are certified recovery houses. In order to get MDRN, you gotta be certified. So you have some kind of outside accountability.
And Kim, real quick, if, so we're gonna keep going.
Sorry.
No worries.
Can I just make one comment to close out? To my request,
Yes.
I think if there's any consideration that we can add to the COMAR 1063 updates, if it's not too late, to add some sort of data requirement that could be made public so that people do have that opportunity to sort the good from the bad, that would be a hugely helpful consideration for the public.
Yeah, I don't know, so I'm just gonna be honest, I don't know if there's anything we can do at the state level, but I think there's something we can do locally to
Yeah.
address that, so, yeah.
And to your point, remember you had an idea about the ranking of the systems, the issue with the law department. I think it was, we had to put them all out there and then, have them rank them and not us. And so like we can, y'all can work on it, but I think because it was just like the restaurant ratings, and there was something that Hillary, I think she had mentioned about like why we can't do it, but if we put it out there, they can do it.
We
Yeah.
can't recommend
Yes, that's correct.
one over another,
Yeah.
but we can note the
Yes,
facts of
that's
what
correct.
they offer.
Yeah,
Yes.
that's correct. Okay. And then with regard to, Kim, when you were talking about the accreditation surveys, the problem that we identified, Councilman, is that the state level was not sharing it with the city level. And so the new healthcare clinics bill that I'm working on, it'll be that accreditation survey upon renewal and initiation will be shared with the BMCA and also with the new Office of Consumer Affairs on the back end if they have a renewal. So like, you are exactly right. We're noticing those issues at the state level, but it's not translating down to the local level. And we're hopeful that we'll be able to close that gap so that the information, if there is a corrective action plan, it needs to be shared with our officials at the local level if they are making those decisions, for sure. All right, Councilwoman Ramos?
Thank you, Madam Chair. Before I get into my questions, I just want to thank you, Madam Chair, for your leadership. Also, you took our questions and our comments from the last few hearings and went to Annapolis to advocate. So I greatly appreciate your leadership on this and representing our committee so well. So I appreciate it. I wanted to just focus. I mean, I'm also a data geek, so I'm just like super excited about what you've started to do and looking at outcomes, but I'm also seeing where there are gaps in care, not necessarily on you, but this is something that I have an issue with the hospitals, and I haven't figured out how to address. Well, I just haven't had time to do it. But, you know, there should be some way that there's information sharing so that the hospital can say, well, this person was with you and having this case manager, so can report back to you and say, you know, can we work together on this particular person? I mean, what we see happen all the time is that no matter what the situation is, especially those who are experiencing homelessness, is that even though we do have case managers in the hospitals, they're still being discharged in the middle of the night with no housing. That's insanity. And so I think there's some room here, especially given the information that you have and some other pieces of information around engaging with our hospitals around how to really sort of close the gap so that you're not discovering because somebody you're in treatment or left treatment and then it just seems too random, and it needs to be more coordinated. And I guess my question is not only to both of you, but also maybe Madam Chair, in terms of how we can have this, you know, can we have this discussion with and I bet money you're already having it with them, in terms of what those communications and data sharing should be. So that we're not seeing somebody come to the hospital 14 times. We're seeing them come once or twice, and they're getting the care that they need outside of the emergency room, right? I mean, it sounds like that's something that you're interested in as well, and Madam Chair, I guess you can answer as well, and I'd love to be a part of those conversations.
Well, I can tell you a couple of things that we're doing. We've approached Hopkins, Wolf Street, because they're right in our neighborhood.
Yeah.
And they were very open to, if we're sending our community outreach into the hospital to talk to clients, we need a little more cooperation from the hospitals, because of course they're wary about people coming in and visiting and
Sure,
whatnot.
I understand that there's HIPAA
We
all
also-
over the place. I know
Totally,
that that's
but
the
they
case.
were very positive about it, and we'll continue discussions with them. In about another half a month, we will have completed an ED app, which will, when that client enters, literally, in real time, when that client enters the ED, we'll have an alert to one of our community outreach workers who will know immediately that client is in the ED and attempt to contact them. Now, initially, we're probably not going to staff that 24 hours a day, so they'll be looking at it at 5 or 6 in the morning and going to the hospitals early in the morning. But we will have an immediate notification system so that right now we have Tableau dashboards that we're looking at, but that app will provide real time and quicker to our community outreach so that we close that gap, because I totally agree with you. The other key piece there is the MCO. We need to cooperate with the MCO to say, hey, all of our clients sign releases when they enter treatment for the MCO. And
sorry,
and the
MCO.
ASO, right? So we need
what's
to.
MCO?
Oh, I'm sorry. That's
Managed
the
care.
people who manage the
Managed
9
care
companies that
organization.
manage
Got it.
Medicaid somatic care.
Got it, yep.
So we need to incorporate them because we know they have resources to close this gap as well. We just need to take the fragments and put them together.
Right, which is, I think, what you were attempting to do.
And
Not
that is
only,
what- yeah.
and it may have been an accidental piece where you're like, well, let's figure out what the outcomes are and go, oh, wait a second, we've got all of these other things that, you know, we end up having to think about because we're seeing what the gaps are. So I would be interested in following up on that. I did get a chance to visit Powell a couple years ago, and I enjoyed that and learned a lot as well. And that was in the process of doing our a bill that we did a few years ago. So I think that having that information is going to be critical, and I'm glad that you've already started the conversations with Hopkins.
And there are hospital partners on the line, and I know that they would be grateful to have that conversation as well. So we can definitely facilitate that for sure.
Yeah, let's definitely do that. My second question is, I'm a little disturbed that there's and I'll just back up before I ask my question, I believe wholeheartedly, and it's in your data, that housing stability is the basis for pretty much everything, right? And that many of your clients are coming to you with housing instability. And then in seeing your flow chart of sort of where all these are going, that partnership with MOHS is not there. And I'm curious what's happening there. There's been some changes, but some good changes, and I want to make sure that that you're able to then work with them based on, whether somebody's coming into treatment, needs housing and goes in that direction, or if it's the other way, and what you're seeing. And also, if there's additional providers that you need to have partnerships with, so that as you're doing that intensive case management, which I think is critical. I've always said we need a legion of social workers across the city to be able to, work with people on all of the resources that folks need, and the care that they need and the tough love that they need, because social workers do this. I am not one, but I know really good ones. And so I just want to make sure that housing piece is front and center when it comes, and the partnership with MOHS is front and center as well. And I'm on the COC board now, so it's very important to me that we're getting these loops properly taken care of.
I would love to discuss offline. We're very anxious to have that relationship. We had an initial discussion in which they told us that they needed consents, and we need to go back to them and say, what consents do you need, and clarify what their needs are, which we are very willing to do. We were developing a lot of other things, but we're very willing to do that because we see that as a critical piece. I would also add that when a client is in treatment at PAL, we have a case manager working specifically on housing and employment, because we see housing, particularly for our dual recovery clients with a lower baseline, safe housing is absolutely the access. It is critical to independent recovery.
That's right.
For our clients who may not be as impaired by mental health, we see independent employment as critical to independent recovery as well. So both of those things. So we have a case manager working on both of those things, but I'm sure that we can find common ground, but I would love to get your assistance, because we also think it's an absolutely critical piece.
Yeah, I'll be happy to initiate that and work through that as well.
And we can also include Councilman Torrance as well, so like having a collaboration between the housing.
Yeah, because he's
and
very
economic-
interested in this particular
the Housing
topic
and
as well.
Development Subcommittee, and this committee as well. So yeah, we can definitely huddle up and see what
Okay.
that looks like. Okay.
Yeah, thank you. I appreciate that. I have a couple other questions, but I can yield to my other. Okay, great. Thank you, Madam Chair. I wanted to go back to the data around how people are coming in terms of their circumstances. It sounds like you're also recording that data and then trying to figure out, because one of the things I'd like to try to figure out is what happened here? Why, people aren't, what happened here? It's a circumstance that we need to make sure that we're dealing with the root causes. And is that something that you can report to us?
Oh, absolutely. We're required to do a complete psychosocial when a client enters treatment. We do it the first day to get the 360-degree assessment. So we have all of that clinical data in the data warehouse. We can slice and dice by whatever way we wish. And that's the power of the system. I only presented a piece because the emergency room is so critical, but we have all of our clinical data so that we can assess who's presenting, what conditions they're presenting in, what severity of dual recovery, how many are presenting without medications, how many are presenting connected to an OTP but need additional residential treatment, and all of the other questions. As you ask more questions, you get better at asking those questions. For outcomes and trends about who's presenting to treatment and what the primary needs are, and more importantly, why those folks are leaving treatment and where they're going.
Which is critical to understand what other circumstances might be happening to where they may be back where they are. I will really look forward to continuing to dig in further. My colleague was clear, we'd love to try to see this much more universal. With our own licensing that, my colleague from the third has really initiated, I think could be really super, super helpful. So I think that we're moving in the right direction. I had one question for Adrian, in terms of the, you know, and Madam Chair had discussed this before, we're still dealing with quality relative to particularly the residential treatment centers and neighborhoods. And it sounds like the COMAR is getting better to be able to help us with those types of situations. And I guess if you could talk a little bit more specifically about that, right? There's the different levels of the PHPs and PRPs. Some of them are going to be in neighborhoods, some of them are not. And that, I think we're really struggling there. And you saw, and Madam Chair had talked about it, you know, what we saw in the paper the other day. We're still not getting and understanding what's really happening in our neighborhoods in those types of situations where folks may be either in an illegal one or they're not being properly monitored, so that, or they're in neighborhoods that there's access to the product that they're trying to get away from. And that doesn't seem to make sense to me in terms of what's happening there.
Yeah. Thank you for that question. And we agree with you. I think there is a problem. I'm going to focus on where BHSB thinks the problem is, which is uncertified recovery residences. So those are housing programs that are offering alcohol-free, drug-free, illicit drug-free, right, housing to people that are not certified by the state. If you are not certified by the state, you are not held to any standard. You don't have to report any data. I don't know what you do, quite honestly, and that's the problem. So we have long held the position that we think if you are operating a recovery residence, you should be certified. There is actually a bill being heard in the House today that would make that a statewide standard. Dan Rabbitt, who I'm sure you know, is there supporting that bill. But I think that is one way to get at the problem. The other way that it might get at this problem of uncertified recovery residents is there's no disincentive that I know of for operating a residence like that, meaning there's no local fine or anything like that to say if you advertise yourself as a recovery residence, but you're not certified, right, that you have to pay a fine or something. We don't do anything locally, to my knowledge, around recovery residents. So I think it's a twofold thing that we need to get at. But from BHSB's point of view, that's where we see the biggest problem is uncertified recovery residences. COMAR does have expectations for recovery residences, that is especially for certified recovery residences. There are new things in there. There are new standards in there for SUD residential care for the different levels there. So those types of programs are regulated and there will be new expectations for them, but it's the uncertified recovery residences that I think create the biggest headache for you and us as well, that we need to address.
My question is a follow-up maybe for the law department that we have to have a separate conversation about is if there's uncertified and unlicensed, the enforcement, because it's a state situation, don't you think the enforcement should be at the state level? Or, I mean,
Well,
Stay tuned.
If I could just,
I figured you'd already
Stay
on
tuned,
this,
yeah.
okay.
Yeah, stay tuned.
I promise I'll be brief. If you can identify the PHP and IOP programs licensed in the state that have MDRN funding, you can then identify the IOP and PHP programs in Baltimore City that do not have MDRN funding. They are most likely to have uncertified recovery houses. And with a cooperation between BHA, BHSB, and Baltimore City Housing to go to the licensed provider site and say, hey, Charlene's from Housing, and we want to see the list of everywhere where you have clients living. Don't fib, because we're going to talk to your clients and they know where they're living.
And Councilwoman Alta said, stay tuned for a bill that's coming about outlawing unlicensed centers in the city of Baltimore.
Yeah, I'm very much looking forward to that and happy to work with you on that. I think just trying to channel the law department here if there's like a fair housing or an ADA situation that we need to be aware of.
Yeah. So we're not
shouldn't be,
saying,
because
yeah,
this
we're
is
not
a
saying,
program, yeah.
we're not saying that they can't be there, which I believe aligns with, you know, the fair housing and ADA requirements. What we are saying is that if you are providing this quality of service, you have to adhere to certain standards.
Yeah, no,
Yeah.
yeah, I think that's right. And there was also, just FYI, a case recently in California that allowed for this particular jurisdiction to have distance requirements. And it was my understanding, based on documentation around the benefit to the client, right? Which is how we have to handle these things. It's not benefit to the neighbor, it's not benefit to us, it's the benefit to the client. And
a great
so,
idea.
yeah, we want to figure out, I haven't been able to find the studies, but there is a study linked to this where it says, like, if you have a concentration, that it's actually bad for the client. So that may be why, you know, that's what the ruling was in this. Anyway, I'll share it with you. I just.
No, that's a great idea. And I mean, if you want to take the lead on that, we'll be here to support you on the other side. Yeah, I don't want to conflate, and this is where I think a few of the legal cases that Baltimore has been in before, they really focused on the concentration, and that's what sparked some of the other legal issues, and so that's why.
That's a fact, and so that's, yeah.
So that's why, like, focusing on the quality and really looking at the quality of said providers and said entities, I think, as a whole, not just specific to substance abuse and mental health clinics, but even primary care facilities, like that, having that that specificity kind of gets us into sticky places. And so, like, having that generalized perspective, I think I think it would go, just off the top of my head.
Well, I think working on both tracks is really important, right? I think that the quality track is probably more important right now. And because there's still a need out there. It's not like we can't, there's still a need, and we want to make sure that people have good care in areas where, you know, we need it most. But we also know that there's concentrations, and then how does that impact the person who needs the care if there's so many around? And I think that's just a question that this case begs us to ask for.
Yeah,
That's
I
all.
would be interested to see how they got around some of the legal issues as relates to concentration, because I remember.
That's a fair housing issue. That's what we've always been told.
Yeah, there was a legal opinion, and I'll see if I can find it in my email, where they talked about, like, the concentration, and they looked at it from a distance perspective. But I can make sure I share that.
No,
with
the
you.
law department has been super clear that we can't
they have?
do.
Okay. Okay.
In the past, they have been clear that we cannot do distance because, like, distance in between, because it's a fair housing issue.
Okay.
That they have been clear about. This particular court case that happened in California may be a way to say, in the way that it's been couched, that the only way to do a distance requirement is as if it's based on, not just because we don't want them, but because, which, you know, again, we need them, but because having a concentration affects the health of the client.
Yeah, that's what I'm saying. I would be interested to see how they quantified that.
Yeah, no, I agree. I'm still working on figuring that out as well. I hear you.
Okay. Yeah, if you find it, send it around to us. I would, whatever they say, I would be interested to see.
Yeah, I'm still studying the issue, but I wanted to
Yeah.
just put it out in the ether as something
I
to
would be
think about.
interested to see how they quantified that. the health
I
of the
agree.
person.
I mean, I think we need, if we're gonna, we may need a study done before we can do anything about that.
Okay.
Based on this, so
Okay.
it's something to think about. Thank you.
Thank you. Any other questions, colleagues? All right, hearing and seeing none. Thank you all so much for being here today. I think this was a very robust conversation. I'm super excited. We have quite a few ideas that came out of this. And so, Kim, thank you so much for being here and sharing your work. Keep doing it. We are paying attention. Adrian, thanks so much for always being a quality partner on the back end as well. Thank you. All right, have a great day, everyone.